Good afternoon, everyone. We're going to ask folks to take their seats at this time so we can get started. Oh, I like how this room just got quiet real quick. That was beautiful. Again, good afternoon, everyone. It is my really pleasure to welcome you to Health Equity Day. This is really a first for the Boston Globe Media Group. As we know, they've done a lot of work in this space over the years, but in our conversations really felt compelled to focus a day on the advancement of health equity. And so for us at Sanofi, it really is our honor to be able to support and to present this event with Boston Globe Media Group today. I am Tanisha Sullivan. I am the head of external engagement and health equity strategy at Sanofi. And for us at Sanofi as a global healthcare company, it's important to note that health equity is more than just a nice to do. It really is a business imperative for us. So whether we're talking about helping to ensure that patients and families and communities have access to the treatment and care they need through our global health unit, or it is the advancement of telemedicine policy here in the US, or even really helping to advance innovation through the utilization of AI and machine learning. It is our goal every day as we chase the miracles of science to help ensure that people actually are able to live the lives that they were destined to live. Here in Massachusetts, we know that this ecosystem is one that is perfectly poised to help lead when we talk about the advancement of health equity. We have all of the components, and I know this room knows that all too well. And so today, as we kick off Health Equity Day, we wanted to kick it off with a conversation focused on AI. Really, AI in healthcare, and specifically how the utilization of AI, machine learning, all of that wonderful technology can actually help us get to better faster in an effort to help us to advance health equity. And so with that, I want to turn it over to our esteemed moderator for this afternoon, Hiawatha Bray, our award-winning journalist from the Boston Globe.
Glad to be here. To my own surprise, as I started getting ready for this, I realized I've actually written a little about this over the years, but that doesn't make me an expert. That's these guys over here, and I'm just going to briefly tell you who they are. I got their names right here. Irene Chen is an assistant professor at UC Berkeley who's working a lot on the application of AI technology to medical care. We've got Colin Stoltz, who is way too busy for his own good. He's a cardiologist. He's a computer scientist. He's co-director of the Harvard-MIT Health Sciences and Technology program. And finally, Dr. Amar Gupta, research scientist at MIT, who's worked in efforts to try to get this technology integrated better into the medical profession, facing bitter resistance every step of the way. Well, that might be an exaggeration, but he'll tell you all about it later. In any case, we're back in the green room there having a great time talking about all this stuff. These guys actually know what they're talking about. So let's begin at the beginning, which is everybody's going crazy about AI, but what we usually are hearing about these days is this new kind called generative AI, and it turns out that AI has actually been around for a very long time, especially in the medical profession. So I was talking to Dr. Stoltz over here, who was telling me a lot about how long AI has been embedded in medicine, and we're wondering if you can explain, where is AI right now in medicine? What is it being used for?
Yeah, so I think it's best to begin the discussion with some definitions because I think there's some ambiguity in terms of what these terms mean. So artificial intelligence, broadly speaking, refers to a class of methods that tend to impart intelligence to machines. Oh, I see Professor Ghasemi there as well, who can comment on this as well as I can. And so that's a very broad class, and the definition is a little bit not satisfying because intelligence appears both in the term that you want to define and in the definition. But insofar as we have an innate sense of what intelligence means, I think it makes sense. A modern dishwasher can perform lots of complex tasks, but no one would say that really that it has any intelligence. So those tasks necessarily impart intelligence, as opposed to translators or things like ChatGPT, which can engage in a colloquy across a broad number of topics, is a different thing. Machine learning is a subclass of artificial intelligence, and machine learning imparts knowledge through large data sets. So it's methods that allows machines to learn from large data sets. Deep learning, generative models are different types of machine learning, fall under the rubric of AI. So, with that preface, artificial intelligence, as instantiated with machine learning, has been in medicine for a long time. So, for example, if I think a lot of people, some people out here are probably in my age group, which is not quite decrepit, but getting there. So that when I go to my healthcare provider, they draw a cholesterol, and from that cholesterol, they do a calculation to determine what my 10-year risk of adverse events is. That is an application of machine learning. It has learned what my risk would be from some set of clinical characteristics. But that's very simple models, logistic regression, linear regression. It's the deep learning, these very complex neural networks that have many layers, many different parameters. That's the new stuff. And that is the stuff that is yet to be embraced by the clinician who sees patients on a day-to-day basis. Case in point, I'm sorry, I'll be just 5 seconds more. So ChatGPT, I think we've all heard of it, right? And many people in this room probably have used it in some way, shape, or form. It has over 100 billion parameters. That's a complex model. And that's sort of the size of these animals that typically appear in a deep learning literature and in applications.
Yeah, but as I understand it, Dr. Chen, you're not using something like a ChatGPT in the medical profession. It's bigger than you really need. It's got all kinds of extraneous information. What we're talking about with AI for medical purposes is going to have to be purpose-built based on huge amounts of specifically medical data. And that raises all kinds of additional difficulties too, doesn't it?
Absolutely. So I would say at a high level, the promise of AI, as Dr. Stoltz very kindly and very well defined it, is that we would be able to take all of these medical records from hospitals, maybe wearable data from people's Fitbits, any kind of information that we could glean together to understand, there's all these people who've come before you, and they've had these symptoms and these outcomes and these interventions that seem to work or not work. How could we use that to better impact people's future health moving forward? Then we're here for AI for health equity. There is a promise that this would be particularly helpful for people who have already been overlooked by the healthcare system, that people who have barriers to access to care, who don't trust doctors very much, or who have had to make difficult decisions balancing off their finances, their healthcare, and other trade-offs, would be able to get better care through the use of AI. Unfortunately, one of the really striking results of the last 5 to 10 years of studying this, in my research and others, including many in this room, is that the data that we feed into these models is in fact already biased. The healthcare system as it exists right now is biased, the care that patients already receive, and so if we naively throw it into the model, we just shove as much data as possible in, then what we're finding is that, garbage in, garbage out, bias in, bias out. So the question is, how can we start to better understand some of this data might be problematic or need cleaning or need further introspection, but some of this data could be useful figuring out how could we better triage future patients or how could we give them better care moving forward.
No, I'm sorry. I thought you wanted to add something, Dr. Cooper.
I'm sorry?
I thought you were going to add something.
No,
reaching, but then add something anyway, because we want to hear from you about your experiences. You were telling us back there about how you do find resistance to the adoption of not just this, but other new technologies by people in the medical profession. I'm wondering if you could explain how that works.
Well, I'll probably start with another example and say how it translates into the medical industry. One of the oldest, or perhaps the oldest use of AI on a national level by a lot of citizens of the country is the process for reading and processing of bank checks. Earlier, it was done totally manually, and I have spent almost my whole career at MIT, but for some years, I used to spend my winters in Arizona, my summers at MIT. If I use the Boston checkbook, gave it to a dealer in Arizona, the dealer would give it to a local bank. At the local bank, two different people would read it to make sure it was read properly. Then it would be encoded, the numbers would be encoded at the bottom of the check. Then it will go on a truck to the designated branch of the Federal Reserve Board, which happens to be in Sacramento, California. So every check from Arizona had to go every day to California. Then it would go by an air courier to Boston, then to the lead bank, then to the local bank, and then given to you. So the cost of processing one check was $1.25, and 44 billion checks were processed in this manner in the US alone. And Switzerland had only one check processing center for the whole country. Every check had to physically come there. So it was an area where nobody looked at it, nobody made any change, there were no forces, the industry was very happy. So we got involved in that area. Is there a way to be able to read it? So we developed new technology, and again, I gave this problem to my students. I said, find a way where you can read 4, and they made all the rules for a 4, and I could still read 4, violating all the rules that they had adopted. So that's where we started using artificial neural networks in the 90s to be able to read that. So we developed the thing, and we patented it, and we were able to apply it in other countries like Singapore. We were able to apply it in Britain. Britain was, again, a unique case. The check had to be in written form, but it didn't say it had to be on paper. So people wrote check on the side of a sheet, took it to the bank, they had to honor it. And here, in the US, the banking system did not want to change at all. They were very happy with it, earning $1.25 per check for 44 billion checks. So the only reason it got adopted in the US is because of 9/11. So do you want to make a guess why 9/11 played a role? Just a quick one. All the planes were grounded, so the checks could not go from one place to another place. So within 3 days, $60 billion worth of checks got stuck in the system. The government had two options, either declare financial bankruptcy at the national level or to have a new way of processing the checks. So they are the ones who passed emergency laws to say that the image of the check should be used instead of the check, and that's how it got legitimized. And my experience is the same with the healthcare field, that number of things which I've been saying for the last 20 years didn't get adopted, and people would ask me what will happen, what will get them adopted, and I said, just wait for the next calamity to happen, and it will happen. And the same thing has happened, that because of COVID, almost everything that I was saying for a long time finally got applied in real life.
But wait a minute, that's a great story. But have we seen the greater embrace of AI in the medical profession because of COVID? Can you give us examples of
I'll
that?
give you real examples.
Yeah.
First of all is that there is a general feeling that if something is wrong, or if some things are measured both by a human being as well as by the machine. Blood pressure, for example, whenever it's measured in both ways, the assumption is that the human being is always right, the machine is the one who made a mistake. That's the general assumption with which one goes. And we have data from Arizona, from Atlanta, Emory University, and we find that the difference is most in the cases of patients who actually die between the human reading and the machine reading. So one interpretation we have is that the nurse is making the patient feel better, oh, you're doing well and all. That could be one psychological reason which might be taking place. But coming back to the main issue, in terms of when we did this work on digital checks, we were approached by people. We did a prototype system for being able to read mammography or mammograms automatically, and for this to be working alongside the human being, human expert versus the machine. And nobody would adopt it, because at that time there was no reimbursement system for it, and without reimbursement, they said, first solve the reimbursement problem for us, then only we are going to allow it. And even today, I can tell you that the features we offered at that time, they are still not available in the systems of today. We were so far advanced in the kind of things that we had done. Same thing in other areas. Telemedicine, for example, a doctor helping a patient, states enacted the laws. So in 2008, I wrote a very controversial paper saying all the restrictions imposed by state governments on interstate practice of telemedicine, they violate the Interstate Commerce Clause of the US Constitution, and therefore all these laws are illegal and inapplicable. I got a lot of hate mail from doctors and lawyers saying, who am I to write it? I don't have a medical degree or a law degree, who should do it? Again, nobody was willing to look at it. And then in 2017, the Department of Veterans Affairs used my paper as the basis to change their entire policy for VA to make it seamless across state boundaries and all. And that has now been adopted by all the state governments over time. And that, again, is a case where the COVID has served as a catalyst to break these boundaries down. Mm-hmm. Now, we still have a lot of other boundaries in medicine. We have one of the biggest problems we have is on electronic health records, for example. Taking hospital records from one hospital to another, how do you do it? And again, to some extent, they made it a little easier during the COVID time, but again, those barriers are going to come back again. So a lot of things which were adopted, some of them are being retained, some of them are not being done. But overall, it's been a major catalyst to the introduction both of digital health techniques as well as telemedicine.
Yeah, but we were talking earlier about this whole problem of getting the data that you're going to train these AIs on. And it turns out, and I guess I never realized this, but it makes sense, there is no like central place you can go to get American medical data. And in fact, I want to talk to Dr. Stoltz about this. He's talking about the wonders of building what he calls digital twins, where you use real world medical data to create a sort of a virtual person inside a computer, and you do it millions of times over as a way of predicting medical outcomes using AI. Tell us about that.
Yeah, happy to. I just want to follow up on, because I think there's an important discussion that it should not be glossed over, and that has to do with acceptance of these methods in the medical space. So there are impediments at the level of a system, right? So there needs to be a reimbursement plan integrated into the medical workflow and such. But at the end of the day, it's a healthcare provider who's going to use this tool to make decisions that are in the best interest, that they believe are in the best interest of their patient. And I think sometimes these points get lost. You have the computer scientist who is enamored with their method. They have a new neural network to do something, and they bring it to the clinician, and the clinician has no idea exactly what this is supposed to do. The clinician tries to articulate a problem in medical lingo, and then the computer scientist is supposed to think about trying to get some solution. This is like a bad marriage, the communication between the two of them.
For you, is it?
Right, but just in general it is. Now, bad marriages can work. As a general statement, it depends on the metric of success. It depends on the metric of success. It's bad in the sense that both individuals talk past one another and speak different languages. But for this to be successful, there has to be some sort of translator or union between these two individuals to attack a common task. Too often this is phrased as if coming up with methods and approaches that will replace what the clinician does. And that is a mode of failure. It is sort of finding the unmet need that will help in the care of the challenging patient and developing techniques that are guided towards those lines. With respect to digital twins, and I'll be really brief. So digital twins are copies of things in a computer. And this has been used in the aerospace industry for some time, right? So you have a plane, you want to modify the design and see whether it saves fuel or other sorts of criteria. You make this in a computer, and you know the laws of physics that dictate what makes an airplane fly, and you can do the simulation to see if there's an improvement. And a similar concept can be applied to people. Can I build a digital copy of myself in a computer? And once I have that digital copy, can I experiment on that individual, things that I would not do on myself? Could I give this computer copy 3 different medications and follow their trajectory and see what makes them feel better or not? And that's a holy grail on I think, in the landscape of medicine. I will say, and the comment I made previously is about 10, 20 years ago, I would say it's science fiction, but today it really is science. And I think we will see this, and it's already being sort of deployed in simple use cases as we speak.
No, wouldn't that be insanely difficult? Because, I mean, what you're talking about, being able to get it down to the granularity of figuring out whether a given drug's going to work, you'd need his whole genome in there, wouldn't you?
Yeah. So
each model for each individual would be like, it would take up a building.
Right. So we don't need to know the genome now when we give medications. I can't think of, patient that I have seen in the last 10 years that I've prescribed the medication with some prior knowledge of their genetic profile or transcriptomics. We don't. So that's not a necessary condition for success. But what you do need are large data sets with a lot of variety, patients that have been exposed to lots of different medications and that you know their trajectory and how they've done over some time. And you want the machine to be able to learn this and reproduce this from some set of patients in some large data array. So I think what is needed in this case is big data sets with enough heterogeneity that will help you answer the question for the specific patient of interest.
Which gets into this whole equity thing because, we were talking about this in the back, and I'm saying, well, if all human beings are alike under the skin, what difference does it make whose digital twin we're looking at? We can get Thurston Howell III or somebody like that and look at his digital twin, and then the results will be perfectly applicable to me, right? Or is that true? Do we not have to find all kinds of different sorts of people?
I'll take this one. So I think the way that we've trained machine learning models, AI models so far has been on pretty aggregate performance metrics. And where we say, oh, the accuracy of this model is 97%. That sounds very impressive. Maybe even when you sort of change things, it seems like it still holds up. The problem is that the 3% that you're not doing very well for are people who you've already not done very well for, who tend to be from groups where there's not as much data about them. Maybe they don't come into the hospital as early when they start to present with symptoms. And downstream, we don't expect that their care will be as good
So
either.
this is critically important. You're saying that, sure enough, these other segments of the population behave in ways such that the stuff you're getting from your AI will not be as accurate for them.
Exactly. And if we define a good model according to, oh, it's 97%, we're good to go, we're never going to dig a little deeper into that, we could be exacerbating existing bias.
Right, exactly. I got it. So the thing to do about that then is indeed to go out of your way, I assume, to find the data from people who are not necessarily, affluent or white or whatever.
Exactly. So I think we can start to open up this black box. I'll give you 2 examples of things that my lab is working on. One of them is looking at the data itself. For example, the language in the clinical notes that doctors write about patients. We have a project looking at stigmatizing language. So when clinicians use certain words like difficult or challenging about patients, this is bad in a few ways. One of them is that it seems wrong because it differs by different populations, but also other clinicians could read that language and also be further sort of biased against
But
patients.
other clinicians might, we were having this argument.
Yeah.
Other clinicians
That
might
might
need
also
to know
come.
it. I mean, this guy's a jerk and they need to know
Exact.
that. But I
But then
understand
if you
your point. If
use
you-
that,
if you
for downstream
Right.
things and you make it for patient note summarization, or if you're using it for things to generate new text, all of a sudden you might be associating difficult patients with another type of, with data, the data that you create automatically says difficult, even if this new patient
Yeah.
isn't quite
Yeah.
difficult.
And we talked also about the fact that it's not at all unusual for example, young black men to be stigmatized as
Exactly.
difficult or scary. There's evidence that happens in public schools where they get disciplined more often. I told you stories about me walking down the street
Oh, yeah.
and having the door locks click. I loved it. I thought it was cool. But it
Happened to me last week.
no. This was when I was a teenager. But the point is that happens. And if you start programming that into the AI, it could be no
Exactly. And especially to Dr. Stoltz's earlier point about ChatGPT having 100 billion parameters, if it's just 3 parameters, like, for example, like kidney function, trying to understand that, you can say, this parameter is kind of suspicious, or like, it seems like it's spitting out something weird. If it's 100 billion parameters and it's over millions of different patients, you lose the ability to really zoom in on what's going on, take a microscopic lens. And so part of the computational challenge is figuring out tools to better understand these models as we go.
One thing I wanted to say, I'm sorry, I agree completely with Professor Chen and what she's doing. And Professor Ghassemi, who's here, has actually done some work in this space. And if you look at the data with respect to medical records in terms of how people are described, you can, there are words that are associated with African Americans, difficult being one of them, and a few others. So this is not fantasy. This is not. This is
What if the
data
patient's
support.
named Tanisha? No, there's been research, not with relating to medicine, but there's been research that if you apply for a job and you got a name like Tanisha, you have a distinctly lower chance of getting the job. It is absolutely been proven by a number of studies. So does that happen in the medical records too? Do you have?
Yeah, so the first step is figuring out, from these notes, can we trace the note, someone writing something that's a little suspicious, all the way down to they receive worse care, or they have different medications for the same clinical state, and also any AI models that we develop on that, will that perpetuate that same disparity? And so that better understanding what's going on in the notes and any downstream AI models trained on those kinds of notes is of great importance. Wanted to make sure that Dr. Gupta get in there.
Well, I want to take a slightly different angle to it. Just now, Dr. Schultz had said that the doctor thought that this would be better for the patient. That's why the doctor did it. Now, it's not always true that the doctor may be better than a human, than a computer, but there are also other issues which we should take about with respect to policies and guidelines. And I'll give you one very specific example. This is a case of a person who got a very nice job in LA. He goes with his wife to LA. In the hotel, the wife falls down, fractures both her wrists at the same time. Is taken by the city ambulance to a leading hospital of that place. And the leading hospital says, yes, both wrists are fractured and surgery needs to be done. But we only take care of our own patients. We do not take care of patients who are not our own. That's what the person said. And then the people told me that this was an agreement which was signed between the management of the institution and the doctors' union to enforce this thing of patient dumping. Right. Now, you can do a search on the web. You'll probably find the name on it. So basically, this thing, the emergency surgery had to be done back in Boston 12 days later because no other hospital would take it. It's a violation of federal law, state law, and local law, dumping law. How do you solve these kinds of things? The way I am advocating is do the same which has been done in the area of education. There was a lady who went to Lehigh University. In the first year, she was raped and murdered. And after that, the federal government, the family worked on it. The federal government has come in with a new way, which has been enforced for 40 years, that all the incidents needs to be recorded. The total number of incidents where they involve a particular place, whether it's a school or anything. Whether the lawyers were able to prevail one way or the other should not be taken into account. And if somebody is an outlier, that is something that needs to be investigated further. So we are actually advocating that we should have patient-reported outcomes in a way which can be handled in a way which can be analyzed in it to find out trends which are very, very troublesome. In this case, for example, the minorities cases who have been dumped is higher than the other ones. And by the way, the person to whom it happened is me and my wife.
Whoa.
And when I complained to it with the federal government, the state agency, and the local agency, it's a total joke on how these kind of things were handled. The best agencies on it, for example, said, we'll take it very seriously, we'll investigate it. And then they said they basically will close the case. And I said, why will you close the case? Oh, the hospital replied to us. I said, aren't you supposed to do anything more? Oh, we don't have resources to do anything more. We asked the hospital to give an explanation. I said, do you know what the hospital said? We don't care what it said. I said, the hospital said, if you're not satisfied with the treatment, you can sue us in a small claims court. That's the answer that they gave us.
Good.
So I'm saying there's no redressal mechanism, and we are finding these issues at many different levels. State medical boards, for example, is supposed to take action against doctors. And again, it's very, very rare that they will disqualify a doctor for life. Very rarely, normally it's for a period. There are examples of a case of a doctor who has been disbarred from practice in 3 states of the US, and he goes to a 4th state, is allowed to practice there, and not only that, he's appointed to the state medical board, one of the authorities on it. The database which is there for the state medical boards to see what is there, everybody's supposed to consult it. Some states have not even looked at the database for years in the past. So this kind of background where we assume that these things will work, in other countries, I've dealt with it, in Europe and other places, they're much stringent, much more thing. If something takes place, they inform everyone. In Europe, for example, you can't even go and practice in another European country, for example. Here, you can just go to another state and practice. So I'm saying these things will have a ripple effect now, especially with the AI coming in. Again, there will be issues where it's been used properly. There will be issues where it's not done properly. Who's going to be oversight on it? Ideally, this oversight should be at an international level, but again, it's not going to happen at an international level. Then it should happen at a national level, and again, state governments are involved very much. So this is, again, a big area where, again, my feeling is, unfortunate feeling is, I have several examples. I gave the example of thing about 9/11 playing a role. I gave the example of COVID. Outsourcing, for example, got legitimized because of the Y2K problem, because they wasn't done it. And here again, in the case of AI, I have the very bad feeling that one of these days we'll have a major disaster, and that's what will get people to really look at these kinds of problems. They're being neglected to a very large extent.
That's a fascinating story. I mean, it sounds like it transcends AI. You're talking about the fact that we don't have a sufficiently well-integrated healthcare system, and layering AI on top of that is just going to introduce a whole new set of problems, because you're not going to have this interchange of information, the ability to see what's going on I guess on a national scale over a population-wide area, and that's going to cause problems, isn't it?
Let me, if I may, let me take an example of healthcare itself. After we did this on reading the information on checks, we were approached by a number of organizations to help them where they work. One of them was a drug company. They wanted us to help them reduce their inventory levels. So they said they had some stores where the drug was only bought once a year. So they'll give us data from the last 5 years, 5 data points. With that, we were supposed to predict when the next sale is going to take place. I gave this problem to my students. They came up with a system which said 90% accuracy is there. I said, no, it's not possible to have 90% accuracy. Go and look at it again. Again, they looked at it, they said it's 90%. Another student, I put 80% accuracy, 90% is there. Go ahead, start a company. And I said, I'm not satisfied with it. I was the impediment on it. I did not allow it to be done. Later, I analyzed the code, and the algorithm was actually cheating on itself. That's what I found. It was not deliberate. That's what was happening. I acted as an independent authority to do it. Eventually, we were able to do much better for that organization. We were able to reduce the inventory by 50% nationwide. But I'm saying at this time, a lot of things which are coming in the market, they are not being verified by anybody who's independent or who should be really looking at these things. And there's no database which is there that what has gone wrong, people keeping track of them, people doing it, people retraining the networks, even that is not specified. And unless you retrain it on the right population, the accuracy of all these new methods is very questionable.
That is another great point. Who's doing that?
Nobody's
I
doing
want to ask everybody here. Yeah, I guess I would actually start with you. You can tell me, I hope you can tell me, whether any effort is being made to look at AI as it's applied to medicine and figure out whether or not it's, if you will, working. Is it actually producing better effects?
I think before figuring out is it working, let's take a step back and what do people actually want AI for?
Great.
That's probably an even better
Yes, it
question.
is.
From last year, in partnership with the American Association of Medical Colleges, we organized a conference, sort of a workshop for AI health equity, and we asked over 400 medical professionals, and there were also patients in the crowd as well, what they wanted with large language models. It's this new, very exciting technology. Everyone has something they want out of it. What do these actual medical professionals want? Overwhelmingly, so we found three things. Overwhelmingly, one, they were very optimistic. They had great dreams about it. You know, this is going to really help me when I'm stressed at night and I don't know how to answer this question. Patients specifically were very curious about having support when they couldn't reach a doctor as quickly. Second one, though, is that they were very worried that this would actually become a barrier in between getting access to a human. They were very concerned that when they needed someone most, yes, having someone to ask quick questions would be nice, but actually they'd like to be able to talk to a human, a nurse, somebody, and not just constantly get shunted to an AI. And the third thing everyone was very curious about was what's going into these models? What kind of data? How are they trained? What kind of promises have been made about these models? And without that kind of clarity, none of the other stuff matters. And so that was very important guiding light for us, thinking about as we develop models, as we audit them, as we figure out what to do with this new future that we live in, how to set up not even formal regulations, but informal regulations within researchers, within clinical professionals, how to better use these AI for health
No,
equity.
now that's a question that worries me too, because it's like when you pick up the phone and you can't get a human and
Oh,
you're
yeah.
always trying to, and the machine just wants to keep talking to you. It's a double-edged sword. There are times, like I call my pharmacy, and I actually like the fact that I can just punch buttons to renew a prescription without having to talk to a human being. But there are other times I'm desperate to talk to a human being, and I can't because they just want me to keep pushing buttons. And that's going to happen with AI, isn't it? Some people are going to, I worry about this. Are people, for example, going to feel frozen out if they can't get AI support? Or are they going to feel frozen out if that's the only kind of support they can get? And couldn't that end up being an issue for underserved people, for poor people, that they end up, give them to the AI. You know, we can't have doctors wasting our time on the likes of him.
Absolutely. And I think the best way to figure out that balance of does this person need a human? Does this person need an AI? Is to ask the patient, to ask the person and say, are you feeling well served by your healthcare system right now? What are the things that you would like things to change or not change? There was a great quote on Twitter recently, which is that, you know, I want AI to do my laundry and vacuum my house so that I can write art and make music. And I don't want it the other way around. I don't
Exactly.
want AI to do all the art and all the writing so that I can clean the house all day. And I think that's the danger of what we're coming towards in this new future, where the AI is doing all of the patient interfacing and somehow the human is left doing all of the tricky corner cases where you need someone to actually go through and read over this garbage and see, oh, this one is wrong, that one is correct, et cetera. But I'd be very curious what the other panelists think.
Well, so I think at a high level, there are a number of concepts that are being conflated here, and I think Professor Chen's comment helps to sort of dissect this out a little bit. There's two questions. What do you want AI to do? What's the task? And that task is defined in part by the patient and the healthcare provider. And they may have different things they want them to do, and I think that's a complex conversation. The other thing is, what does it mean for AI to work? What are the metrics of success, right? So the patient has their own metrics, the clinician has their own metrics, and hopefully there's some synergy between the two. This notion of sort of having a data set to measure accuracy is a necessary condition for success, but it is not sufficient in and of itself. So you want a model to have high accuracy, high performance across many different data sets and such, but is that enough? So if a model correctly predicts that you're going to, a patient at high risk of death is going to die in 12 months and gets it right 95% of the time, that's great, unless you're part of the 5%, right? I mean, so, when we talk about death rates in the cardiovascular space, 1%, 5% per year is really high. That's really, really high. So working has to mean more than just some overall number about what the accuracy is on a data set. You want to know if the model is appropriate for a given patient. When a patient sits in front of me, I can have an accuracy and all these statistical measures of success, but is it right for this patient sitting right in front of me? And so I think we need to have additional metrics of things that tell you about the uncertainty. Is it appropriate to apply the model here, right? And I think that is another complex conversation that often gets ignored in this conversation.
I wish you could explain that more. I didn't quite get it, because if the model is accurate and they're saying, this guy's in the 5%, it's good to know, isn't it? I mean, that doesn't sound like a
Well, so
failure.
the difficulty arises, so if a patient comes to me and the model says this person is not at high risk of death, so it's wrong, but they really are. And I know that there's interventions that I could do that would prolong their life, then I've missed an opportunity to intervene
But
to prolong a life.
that's where the model's wrong, isn't it?
But I don't know that a priori, right? So the model gives me a statement. I don't know when a model's wrong. And my point is that in addition to a prediction, a statement is to say, well, I'm pretty confident about this prediction. I'm not confident about this prediction, so you should ignore it. Or I'm very confident about this prediction. That's additional data, I think, that a healthcare provider should have to integrate this into how they do their for their clinical decision making.
You put it really well back when we were talking in the back. You were talking to me about this, and you said, I don't need AI when somebody who's like 20 years old and in perfect condition walks into my office. You're going to be fine.
Right, yeah.
And I also don't need AI when the priest is standing over the bed.
Yeah, so I think
It's the people in between.
Right. So a model that predicts death, for example, if I walk into an intensive care unit and outside, and I see a patient, and outside the door is a patient's significant other, a rabbi or a priest or a or a minister, I don't need an algorithm to know that patient is going to die imminently, right? It's the difficult cases that really AI can play a role, and because they're difficult, I guess it's kind of a syllogism. It's they're hard,
Right?
Right, hard for me, and often hard for the algorithm. So if the algorithm can tell me as well in these cases how sure it is, I think that would be very helpful.
Okay, but I was trying to figure out how we're going to get this data that can be used to train all these people if it's all in all these little separate silos somewhere. And I wanted to ask you about whether or not there's any way to solve that particular problem, because those of us who were born at like Cook County Hospital in Chicago as opposed to being born at like Northwestern University Hospital are going, yeah, you really should check out the people who were born at Cook County. And if you're not getting that data, you're not getting the whole story. So how do you make sure you get that data?
You want to take it?
No, please. Go ahead.
Well, I think there are two kinds of problem. One is the source of the data itself. All of them have custom made. Many of these are proprietary systems like Epic system and Cerner system. And the other is the shareability of this information. Can you do it or not? I'll give you a previous example. At the time of the Grenada War, the pilots in the air could not talk to the soldiers on the field because they were using different communication equipment and different frequencies. So after the war, President Reagan got upset and said, enough is enough, and set up a new thing to integrate that information of there, and I was involved in that process of doing it. So one of the approaches we developed is called the mediation approach, which we have suggested for a long time. And the one which has the best system, which could have done it, is the VISTA system of the Veterans Administration. It's been in existence for a long time. It is much more homogeneous. It's been used both on the surgery side as well as the medicine side. Unfortunately, during the time President Trump was Trump, that contract was taken away and given to a private company at a cost of $17 billion, and that's been a total disaster at this point in time. So if anything, we are going backwards in this area rather than forwards in terms of it. There's no unified system, and all the efforts which are there are piecemeal efforts. So this problem is going to continue, as far as I'm concerned, for the foreseeable future, unless we have somebody who really comes in a big way and imposes the will. The only option which is left is, A, to take data from a foreign country, like other countries have done a much better job of having homogeneous data. In Korea, I'm told that even if you go to your exercise, even that exercise record becomes part of your national health records, for example. Israel has done a very good job in terms of integrating information, but Estonia has done a great job. But again, it's a major problem, and again, it's very, very difficult to do this kind of integration at this point. And if anything, as I said, it's going backwards rather than forwards with the decision with the VA to giving it to Cerner.
So is there any initiative being developed to try to come up with a way to equitably acquire the data you need to build really good AI models for healthcare? It's all just piecemeal and...
It's all piecemeal at this point in time. In fact, there was a movement before COVID took place by one of the EHR vendors that patients should not be having a right to their data, and they started a national coalition on it, and some of the best hospitals are members of the coalition where they were trying to deny access to it. So only one state clearly defines who owns the data, which is New Hampshire. All the others was confusing. In COVID time, they've done some piecemeal attempts to do it, changes. Again, they're not homogeneous in any way. And again, it's really confusing. I'll give you one example which all of you can relate to. In the US, federal law normally supersedes the state law, if there's a thing. It's the opposite in the case of privacy. For data privacy, the government has said that whichever gives more privacy to the patient will be the applicable order, whether it's federal or state. Mm-hmm. So at one point, federal government said, we have taken care of this whole issue, and we have dispensed with it to do it. You can't just do it unilaterally. You have to work with the state governments in order to do it. Mm-hmm. And today, for example, California law requires, privacy law requires, that if a California resident goes for treatment anywhere in the world, including China, the California rules of privacy will apply to the interaction between doctor and the patient. That's the kind of rules we want others to follow. Mm-hmm. And it's just not going to become real in any way. So again, it's very piecemeal. Again, in my view, it should be done at an international coalition level, especially in healthcare, because medicines are sold across national boundaries. With telemedicine, we have examples of telemedicine across national boundaries, but there's no initiative at the international level.
Well, that sounds like a mess, because I've been writing about this for years, not about the medical part of it, but about the fact that the United States is one of the few industrial countries that does not have a federal privacy policy overall for anything. Most other countries have some kind of law. We have HIPAA, of course, we have some financial regulations. In those two areas, we've got pretty strict laws. But an integrated privacy law doesn't exist in the United States. So it sounds like what you're saying is we're not going to be able to fix this anytime soon.
I want to point out there have been some patient-led efforts, so from the bottom-up approaches. One of them is that patients with one disease, for example, multiple myeloma, have sort of banded together and voluntarily shared their data to disease registries, where people who want to focus just on this one disease can get people, on the order of thousands of patients who say, here's all my data, use it to improve science.
By the way, how did they get their data?
You can request your own patient access through the Cures Act from 2 years ago. Now all patients have access to their electronic health records. They're entitled to that. Congress has deemed so. And then the other effort is something like the All of Us effort that was led by the Obama administration. And there, patients also volunteer their data. And they say that, oh, my hospital is allowed to share it with this data initiative. And also, I will fill out a lot of surveys that researchers can get access to as well. I totally agree with Dr. Gupta that it's very fragmented and there's very small efforts and not a lot of success that we can point to. But I'm optimistic that some sort of empowering patients can lead to more movement about data being shared when they want to be.
Is there any kind of an effort to get for example, black people to contribute to this kind of thing, minorities to start voluntarily sharing their information?
The All of Us data effort was imagined, as many of these things go, the dream was that it would be specifically for diverse populations. So
Right.
it's not meant to be representative of the United States. We have a lot of very large groups that are already represented in healthcare data settings. This one was specifically targeting people of minority races, of gender that might not be appreciated, or the kinds of data that we might not get a lot.
And I just want to sort of echo back to something Professor Chen said at the outset about the bias that is inherent in these data sets. And sometimes more data isn't always good. And I think this is something that Professor Chen can speak to with much more erudition than I can. So everyone is biased, human beings are biased, and that is not a nefarious statement, that's just a fact, this is what we are. And that bias seeps its way into the data sets that are available, it seeps its way into the way that we evaluate these models, and sometimes even the way that the models are built. And dissecting all of that is very, very, very challenging. And I think it is an impediment to this field that it is so challenging to get data sets from diverse populations across. These patient-led initiatives, I think, are a start, but my concern is that they represent patients that may be more well-informed at the outset or have a higher socioeconomic status than others. So while I think that these are steps in the right direction, I think it's far from dispositive.
Yeah, that could be a problem. I mean, I immediately think the minute you think of that, you immediately go, uh-oh, the Tuskegee experiment, which has this historical legacy of making black people a little less trusting than they might otherwise be of the idea of handing off their medical data to other people. It's going to be a problem. I wanted to ask you, as you talked earlier, we were talking about the kind of AI that we are all playing with now, generative AI, which is very different from the AI that medical people have been working with most of the time. And you were telling me that you don't think today's generative AI is a whole lot of use for people in the medical profession right now, at least.
Yeah, it's kind of like, Star Wars, right? No, not Star Wars. What was the thing, the Enterprise? What was that? Star Trek. Yeah, it's kind of like Star
Why do you
Trek. That's
call
more in
yourself
my...
a nerd?
Yeah, no, that's more in my... I remember that when I was younger. So it's a great idea. It's fascinating. Would I really want a light beam to transport me from one place to another? I'm not quite so sure. So what am I trying to say in a very odd way? That this technology sounds great, but it is not ready for prime time. In part, so as a case in point, so ChatGPT does many things well, but we can all find examples, especially in the science sphere. There are some biochemical questions that you can ask ChatGPT, and it fails horribly. And until we're able to really dissect when these methods can give appropriate answers or not, they're not ready for prime time. What is the dream? I think the dream is, and I think this has already been alluded to previously, is a patient who can ask a question to some algorithm and have that answer be distilled in language that they understand without a lot of medical garb. I think that is but we're not there yet, far from it. A healthcare professional who is seeing a new patient, and they have a panoply of data to go through. So there's lots of data about that patient, electronic health record, but they have a specific question. When did this patient have a myocardial infarction? When did they have a heart attack? Did they ever have a history of heart failure? If they can ask that question to an algorithm that can go and peruse the chart and effectively bring back a correct answer expeditiously, I think that are two clear examples in which this technology can be. But at present, right now, and at least I think for the foreseeable future, it's just not a good thing to use in either of those applications.
So you can't just walk into the sick bay of the Voyager and the thing appears as state the nature of your medical
So
emergency.
the Voyager was a little bit after, so I like the William Shatner, right? So that I can't. But right, you get my point.
I'm wondering if I should take a question or two. Do you think that would be worth doing? Does anybody have a question that they would like to throw out here? I don't see anybody moving. I'm going to give you. Okay, can you? Oh, I don't know. Did anybody? I'll do it. What the heck?
Hi, thank you. Joan Reed from Harvard Medical School. It's a different kind of question. You're talking about pulling together large amounts of data and applying them towards patients. Can you use it the other way of large amounts of data to understand more about the providers and the kinds of decision-making in other places to intervene on the provider side?
Stay out of that hospital.
So there are, exactly as you say, and Dr. Reed, it's good to see, I don't know, you don't remember, it's been some time. So there are companies that are built on that premise. So there's a company, Health at Scale, that comes to mind that precisely tries to do that. And the goal is to take a patient, looking at large data sets, and map them to the optimal provider. Now, what optimal means is varied. Does it mean that the cost will be less, or does it mean the outcomes are better? So the questions that you ask now are very apropos because they're being asked across the field.
That is actually a heck of a good question, because I wonder if you could make that work, because how would you get accurate, honest, you would have to compile accurate information from the providers themselves, and they might not be all that eager to share it. Is there any way to actually do something like that? It's a great idea, but how do you make it work? Is there any,
So these companies that
would you need a law? I mean, for example, might need a law to require the reporting of certain parameters so that you could put something like that together?
Right. The company and the technology that I am referring to, and there's more than one, do it with incomplete data sets. There are times that healthcare, but there are some healthcare entities that have shared their data in this regard, but it is not a universal thing.
You should take that up with a member of Congress. That is a genuinely good idea.
New Mexico was the first. I'll give you an old example. New Mexico, under the privacy law, when they allowed telemedicine to take place, they said every telemedicine encounter has to be video recorded. So that's one way to force people to record. I don't know whether it's
I don't know about the video, because that raises privacy issues
that's-
as well, but you could come up with other ways
Correct.
of doing that that would really be very useful. Anybody else? Oh, here you go.
Hi, I'm Juan Fernando Lopera. I'm with Beth Israeli Health, DEI officer for the system. I'm also one of the co-founders of the Health Equity Compact, and there's a number of Health Equity Compact members here. The question I have was the use of race, ethnicity parameters. We have seen efforts to actually de-racialize algorithms, right? For kidney function, race was being used and it was leading to poor outcomes. So actually get rid of race in its application in these models. How do you think about the use of race, ethnicity, language parameters to